good afternoon and good evening to all of us who are joining from rest part of the world. Today, our guest speaker for the day is Dr. Pushpanjali Oja from Ranchi, Jharkhand. And she's going to lecture us on diagnostic challenges in hemophilia care, past, present, and future. This webinar is brought to you by Mumbai Hematology Group, supported by Roche, Accurane, Lucien, and Nirvin Life Sciences, and managed by Perfect Square. I thank Dr. Apurva Verma and Team Roche, Team Nirvin, Team Accurane, and Team Lucien. I thank Mr. Yash, Mr. Kalpesh, and the Team Perfect Square, Executive Committee of Mumbai Hematology Group. Our chief guest for the day, Dr. Abhishek Dudatra from Ahmedabad. Our guest speaker for the day, Dr. Pushpanjali Oja from Jharkhand, Ranchi. All our discussants who are themselves very eminent pediatric as well as adult hematologists, and you participants for spending the Sunday morning, afternoon, or evening from whichever part of the world you're logged in. Let me give a flavor of our next weekend activities. Next Saturday, that is 8th of June 2024 from 7 p.m. Indian Standard Time onwards and 8:30 US Central Time, we have Dr. Maury A. Gertz from Minnesota, USA speaking to us on Waldenström macroglobulinemia and update. And the following day, that is Sunday, 9th of June 2024 from 11:30 a.m. Indian Standard Time, we have Surgeon Commander Dr. V.A. Arun from Mumbai speaking to us on multiple myeloma, choosing treatment regimens wisely in our country. Let me introduce our discussions for the day and here displayed in alphabetical order. To start with, we have Dr. Arun V.A. from INHS Aswini Kolaba, Mumbai, Dr. Bipin Kulkarni from KM Hospital, Mumbai, Dr. Chandrakala S. from KM Hospital, Mumbai, Dr. Dhyaneshwar Upase from New Life Hematology Center, Wakad, Pune, Dr. Dibaditra Ray from MedGenome, Bengaluru, Dr. Ekta Jajodia from Uniped Specialty Laboratory, Ahmedabad, Dr. G. Vikram Kumar from ESIC Medical College Hospital, Hyderabad, Dr. Kapil Garg from SMS Medical College, Jaipur, Dr. P.K. Sasidharan from Government Medical College, Kozhikode, Dr. Parth Ganatra from Bhai Jagbai Wadia Hospital for Children, Parel, Mumbai, Dr. Radhika K.K. from Nizam's Institute of Medical Sciences, Hyderabad, Dr. Rucha Patil from KM Hospital, Mumbai, Dr. Shailendra Prasad Verma from King's George Medical University, Lucknow, Dr. Shashikant Apte from Saidri Hospital, Pune, Dr. Shweta Bansal from LTM Medical College and LTMG Hospital, Sion, Mumbai, Dr. Siddhesh Kalantri from Blood Care Hematology Clinic, Nashik, Dr. Tulika Seth from AIMS, Delhi, Dr. Varun Bafna from Dr. Bafna Star Clinic and Hospital, Kolhapur. Now is the time to introduce our special guest for the day, our chief guest and a very dear and near friend of mine. We have with us Dr. Abhishek Dudatra from Ahmedabad. Dr. Abhishek Dudatra is MBBS, MD in Internal Medicine, DNB Hematology, as well as fellowship in BMT from NUH, Singapore. He is also director of Hematology and Bone Marrow Transplant at HCG Cancer Center, Ahmedabad. It's my privilege to invite Dr. Abhishek Dudatra to inaugurate our webinar and give some words of wisdom. Over to you, Dr. Abhishek Dudatra.
Hello, good morning to everyone, and thank you, Amit, for very kind introduction. I'm extremely grateful to Mumbai Hematology Group and MB Agarwal sir for giving me this opportunity. So I welcome our today's speaker, Dr. Pushpanjali Oja, who is going to speak on a very interesting laboratory topic, that is diagnostic challenges in hemophilia. That will be followed by a discussion. I also welcome all the participants and discussants, many of whom are my good friends. And I'm really fortunate that my mentor, Dr. Shashikant Apte sir, is also present here today. So my association with Mumbai Hematology Group is long-standing. From first year of my training, that was back in 2012, we have been attending MHG events. Of course, there were no webinars at that time, but as usual, MHG had regular academic events in person. So we do have fond memories of traveling from Pune to Mumbai, attending these events, participating in quiz, presenting posters, and of course, listening to Star Wars of the field. And I really feel privileged that Agarwal sir has continued to invite me till date, even as a faculty in various events. But I must say that this is the most difficult task he has given me till date, to share words of wisdom with youngsters in the field. So, talking about the field, I feel that hematology is one of the most interesting and definitely most rapidly evolving specialty of medicine. If we just look at the history of hematology over last 7 to 8 decades, starting from development of chemotherapeutic protocols for leukemia, starting with just methotrexate, evolution of cellular therapies from stem cell transplant to now CAR-Ts, and also the parallel development in laboratory science and immunology is so inspiring. And everyone would agree that last decade has seen groundbreaking changes. Any disease you take, we have new molecules, and patient outcomes have improved drastically with very limited toxicities. Many of the patients now we treat at home. Having said that, despite all this, development, if we take just hematological malignancy patients, we still lose battle in, I think, roughly 50% of patients in long run. So there has to be there is a huge vacuum that needs to be corrected, and contribution from everyone is very important. Not only new drug development, but in countries like us, refinement of present protocols, supportive care, infection control is extremely important. And to do that, I think development of team and system wherever you are working is extremely important. This was always emphasized by my mentor. But once I started working, I realized that how difficult it is. So contribution from lab, nurses, blood bank, even social workers, equally important. So I think, yeah, everyone has an opportunity to contribute to this novel cause. And yes, so that's it from my side. I think we all are eagerly waiting for the lecture. And thank you once again to Agarwal sir and Mumbai Hematology Group for this opportunity. Over to you, Amit. Thanks.
Thank you, Dr. Abhishek, for that wonderful and kind words. And thank you for accepting our invitation to be as a chief guest for the day. Thanks a lot. So now it's a time to introduce our guest speaker for the day. We have with us Dr. Pushpanjali Ojha from Ranchi, Jharkhand. Dr. Pushpanjali Ojha is currently pursuing assistant professor come in charge post in pathology at RIMS Trauma Center, Ranchi, Jharkhand. She did her MBBS from Jawaharlal Nehru Medical College, Bhagalpur, Bihar, and MD in pathology from Army Hospital, Research and Referral, New Delhi. She has over 8 years of post-MD experience in teaching in various government medical colleges. She has done observership in cytogenetics from CMC Vellore, CHCC in hepatopathology, medical education research and publication, MERP, artificial intelligence in pathology from MEU India, and other certificate courses like academic and research reporting writing, that is ARRW, basic course in biomedical research, that is BCBR, from Swayam Portal Curriculum Implementation Program, that is CISP, etc. She is pursuing PhD in molecular biology from RIMS, Ranchi. She was awarded with Best Young Faculty Award in 2021 and Best Poster Awards in 2022. She has over 15 publications with more than 30 citations in various national and international index peer-reviewed journals. She has written book chapters and reviewed journal articles. She has received research grants for 1 intramural and 1 extramural project as PI and 2 extramural project grants from ICMR as co-investigator. Her subject of interest is hematology, and she enjoys learning and updating herself with a recent advancement in healthcare, especially hematology. Hemophilia prophylactic therapy is administered in the state of Jharkhand by Hemophilia Federation, India, in coordination with NHM. These patients require regular monitoring of factor level, TRUF, and early recognition of development of inhibitors too. Recently, emicizumab is introduced as prophylactic drug for hemophilia patients that will overcome some of the challenges. And today, she is with us to lecture us on diagnostic challenges in hemophilia care, past, present, and future. Well, thank you so much. Over to you, Dr. Pushpanjali Ojha.
Am I audible, sir?
Yes, you are audible. Please go ahead.
Okay. So let me share my screen. Is my screen visible, sir?
Not yet.
Is it visible now, sir?
No, we cannot see your screen yet.
Okay. Sir, I'm not able to share my screen of this PPT.
Uh, Mr. Kalpesh, can you please help her?
Sorry? Sure, sir.
Okay. So is it okay for you now, Dr. Pushpanjali?
Yeah, is it visible to me?
Please go ahead.
So first of all, thank you, sir, for your this kind introduction, and I am very have very feel honored to be part of this such an academic platform of hematology group. I am thankful to the Agrawal sir and the entire hematology group to giving me such an opportunity. Today, I am going to discuss about the diagnostic challenges in hemophilia care, including the discussion about the past, present, and future. Next slide, please. I'm going to discuss my topic under the following headings. First is history, followed by pathophysiology of hemophilia, diagnostic modalities available for hemophilia, and the diagnostic challenges we are facing with diagnosing in the for hemophilia and diagnosis of hemophilia with future perspectives. Next slide, please. So, as we know, hemophilia is a bleeding disorder. So, here this slide will show the overview of the entire bleeding disorders, which are the result of the impending abnormalities in the most important three factors. One is the endothelial cells, second is platelets, and third one is the clotting factors, which are playing their role in maintaining the hemostasis. So, here I am mentioning some of the important diseases which are related with the abnormalities of platelets, endothelial cells, and clotting factors. Among the clotting factors, hemophilia is the commonest one, which is going to discuss about the hemophilia. Next slide, please. So coming to the history of hemophilia, there is an uh, era of hemophilia will be divided into two basic groups. One is era of disease identification and diagnosis, and another one is the era of treatment and prophylaxis. Among the era of disease identification and diagnosis, this will as old as our human civilization. Like in second century, we have a description about this disease, but they haven't named this disorder. This is a description from Talmud, Jewish rabbinical. There they presented their observation that the male child should not be get circumcision process if their two male earlier siblings are get death because of the similar procedure or excessive bleeding. Then coming to the 12th century, here again an Arabic physician called Albucasis have also observed a similar thing that some of the families have the has history of death among their male persons during the trivial trauma. After that, the 1800s was a very important decade in which there are so many developments which have come. These are, next slide, please. These are In the 1800th century, the first modern description of hemophilia came in the 1830s. That is the initial stages of the 1800th century. In that century, the was first used by this called Hoff from the University of Zurich. In 1837, the disease is diagnosed as the royal disease because this was a very common disease among the European population. Now, in 1800th century, the cause for hemophilia was identified as the defect in the platelets, and in 1952, hemophilia B was diagnosed as the Christmas disease. Next slide, please. After that, in 1900th century, there were some major events which are related with the starting of management of this disease, which includes the development of anti-hemophilic globulin, then followed by the use of plasma-derived factors or for exchange among the hemophiliac patients in 1944. And after that, the people had been success in fractionation of description of use of fractionation of plasma for the treatment of hemophilia. The first very important discovery was in 1960 when cryoprecipitates were used as a factor replacement therapy. 1964, the first time the factor 8 was available in a very small volume with larger activity in among the for the hemophilic patients. In 1970s, first golden era was because of the availability of lyophilized plasma concentrates of the factors and widespread adoption of home replacement therapy. It was the boon for the patients because they are now able to get the therapy at their home. After that, primary prophylaxis was also started in 1970s, and there was also an important event which occurred in 1970s was discovery of desmopressin, which had increased the level of factor 8 and voluminous factor among the patients having mild or moderate hemophilia. In 1980s, when the people are very used to with these replacement therapies, one disease or you may say the some viral induced diseases which were get started to be transmitted among them are HIV, hepatitis B and C. So there were more than 60 to 70% patients who had receiving this replacement were get infected with this such disease. So this was a very big challenge for the physicians to get control over that. And after that, with the development of the heart therapy and viral screening and screening procedures and government policies, this disease challenges will get overcome. And now we can then after that the replacement therapies with viral treatment of the products will be started. In 19 the as far as the diagnostic part of this disease is concerned, in 1980 and 84 was the very important years when genetic profile of this disease was discovered with the diagnosis of factor 9 or factor 8 gene, which were used, which were identified as a positive agent for this inherited disorder. Next.
Just a minute. Can you just see some of them is on mute? Can you please everybody mute? Thank you.
So as you know, hemophilia is a genetic disorder, but this is not a very true thing. Nowadays, we also know that the hemophilia is not only a genetic, it is also an acquired disorder, which is because of the deficiency or inhibition of the factor 8, which is called hemophilia A, factor 9, hemophilia B, or factor 11 deficiency, which is called hemophilia C. Thus, based upon the severity of the disease, disease is classified on the presence and degree of the presence of the factor activity, which is normally we used to say that 50% of the factor activity will be capable of withstanding the hemostatic mechanism of the body. So less than 40% will be considered as the deficiency, which may cause the clinical presentations of this disease. So severity of hemophilia is classified based upon the factor activity, that is mild, moderate and severe. And average age at diagnosis, that is the first presentation of bleeding among the patients who are suffering from various degrees of hemophilia are, these are varying with the severity of the disease. The earliest age which was reported was the 6 months onward, and it was associated with the severe hemophilia, whereas the mild hemophilic patients may come to their disease first bleeding episode at the on an average age of 6.5 years. Next slide, please. Come to know the prevalence of the disease. Hemophilia A is a common bleeding disorder among the other type like hemophilia B, C, and mild to moderate hemophilia have 37 to 42% prevalence among the middle to high income countries, which is, and it is quite low among the low income countries, but it not the data will not be giving the correct picture. There are various challenges which are responsible for this low data, so might be these variations are similar among the middle and high countries as well as in low income countries, but because of the limitations in the diagnosis and identification of these disorders, the data is lower among low income countries. At present, in India, approximately 20,000 cases of severe hemophilia are registered across 74 hemophilia chapters. And next is the we as we know that hemophilia is replacement therapy is also associated with the development of inhibitors. So the data for hemophilia inhibitor development is also showing that severe hemophilia have a high level of development of these inhibitors, that is amounting 30% of the previously untreated patients. Next is prevalence of inhibitors in India is 8.2 to 13%. Yes. Next slide, please. So hemophilic patients have the different presentations depending upon the severity of illness. The mild disease will show bleeding due to the severe trauma, and these patients are usually present at the delayed age, and followed by the identified during the bleeding during major surgeries. They have very less degree of deformities or complications because they have very short duration of the exposure to such frequent bleedings, and they require the therapy for this replacement only on demand whenever they have this bleeding episodes or they are planned for any kind of surgery, then only they have required this such kind of therapies. But as we see on the over extreme of the this disease like severe hemophilia, these patients will present with bleeding at the time of birth only. Like we observe that there is prolonged delayed blood cord bleeding, so that time they will get identified, or after when the baby start crawling and movement. So in their early age they have diagnosed with bleeding. These patients are also have a more tendency towards spontaneous bleeding, which may involve the larger joints like hemarthrosis, muscle hematoma, CNS hemorrhages, epistaxis, hematuria, menorrhagia, which may be life threatening in some times. These patients also have severe deformity and early development of complications because they have these bleeding episodes in their early ages of life, and these patients are the good candidate which are put on prophylactic therapy as soon as possible of their life. Apart from that, because these patients are having a higher exposure of replacement therapy, so they have the tendency of development of inhibitor in higher in comparison to the other groups like mild and moderate severity of hemophilia. So these patients also have a high demand for the on demand therapy or for rebleeding or development inhibitor development. Next slide, please. So coming to the understanding the cause of the disease, for the pathophysiology of hemophilia, what happens inside the body when this bleeding disorder will develop. So hemophilia is broadly of two types: inherited and acquired. In inherited, we all know that X-linked recessive disorder is the most common type of inheritance. But apart from that, there are autosomal dominant, which are due because of the defect in the von Willebrand factor, and inacquired due to presence of inhibitors and immune mediated. Next slide, please. So this is a just a diagrammatic presentation of how this hemophilia will transmit in the family in case of inherited hemophilia disorder. Here is this is an pictorial presentation among 4 generations of a family, in which if the first person is male with hemophilia, all the daughters are carrier, but there is no any person who is showing any kind of bleeding disorder. So and the third generation, if the that carrier female will have married with the male, normal male, then the 50% of her male child and the your one of the daughter is carrier. So our main point of interest over here, as far as the diagnostic challenges are concerned, are the generation 2. These patients are usually asymptomatic, unnoticed, and they didn't have any problems, so they haven't go for any kind of screening procedures. And these are the persons who are responsible for the from transmitting the disease through the generation 3 and 4 of their family. Next slide, please. Irrespective of their cause, like inherited or acquired, whatever is the factor, if there is a problem in the factor 8 or factor 9 deficiency, these are the factors which are taking part in the intrinsic pathway of coagulation. Then and they are the important component of teenage complex of the coagulation pathway. They get deficient. That's why the primary the fibrin monomer which are forming in the coagulation cascade are of very uh, minimal in amount, and there is no cross linking. So fibrin mediated clot formation and its stabilization was not possible in case of hemophilic patients. That is why there is the whatever clots are formed, they are just because of the activation of platelets. So these are only primary hemostatic plugs. The secondary hemostatic plugs are unable to form. That is why these plugs are not very strengthened to prevent the bleeding. Apart from that, in case of when the bleeding occurs in the joints or area, there is release of cytokines which may lead to redox reaction, and after that chondrocyte apoptosis. This will lead to the synovial cell proliferation and destruction or erosion of the chondrocyte plate over the joints, and lastly of the fusion of the joint, leading to deformity. Next slide, please. If the disease is remains going into its natural course. Next slide, please. So, what about the treatment? So, there are treatment options available for hemophilia, which starts from the factor replacement, and now we are progressing from not only giving the on-demand therapy. The factor replacements are of two types, either plasma-derived or recombinant, and both of are of short half-life and extended half-life. Apart from that, there are the other agents which are developed to treat the patients are bypassing agents, which which treat bleeding among people with hemophilia who have developed the inhibitors. Apart from that, hemostatic agents like tranexamic acid and IACA, non-factor replacement therapies which are in now treatment of choice, or in the nowadays they are in patients are accepting these drugs like emicizumab, which is very good, giving a very good response. From 2017, it was introduced. Then ifanesoctog alpha, Altuvio, then desmopressin and aminocaproic acid. In gene therapy, the gene therapy is under trial, but it is not established because it is under a phase 1 and phase 2 trials are going on them. Apart from that, there one also drug fitusiran is also introduced, but not in phase 3 trial. Apart from them, hemophilia A gene therapy, there is an FDA approved, but it was not coming into the market. It's AAV5 viral particle was used. Hemophilia B gene therapy is also available. These are the future aspects of the hemophilia treatment options available. But nowadays, since we have the plasma derived and recombinant options which are given to the patients at their daycare centers also, but with the good their response, but they have some limitations like thrice a week their administration. Emicizumab have single dose subcutaneous loading dose at a weekly and followed by monthly injection. So these are the modalities which are now people are using. Apart from that, the blood components like ffp or cryo are also being used in such some situations. In bypassing agents, the FIBA and protein prothrombin complex concentrates are used. Next slide, please. So, based upon this overview, here we are. Where are the problems? What are the challenges? We had diagnostic modalities available. We had the treatment procedures or treatment available. Society. There are various societies and organizations which are working for these patients. So, what are the challenges now? So, the challenges are still there is lack of medical and patients awareness, underdiagnosis or overdiagnosis of the disease, most importantly misdiagnosis because of the unusual non-suggestive presentation or outcome which people are not thinking that they are related with this disease, which will and some data shows that approximately 20% of the people with hemophilia do not follow their prescribed treatment. That's why they often present with the rebleed and development of inhibitors, which are the again a challenge for treating or providing these patients with a higher level of factors. Apart from that, there are most important challenges which we Indians are facing are under presence of under resourced laboratories, where the coagulation profile and genetic tests are not available. Apart from that, cost of laboratory investigations and therapies and the logistics related with all these diagnostic and therapeutic and follow-up procedures are also a challenge in managing the patients with hemophilia. Next slide, please. So as we know that 30% of the patients who are on factor replacement therapy develop factor 8 antibodies, and this will impact the quality of life of the patients and the treatment plan among these patients. This also lead to 36% school dropouts among the patients. 51% of the patients were unemployed because of the disorder, and 85% have morbidity developed in 5 to 12 years of their age. One data shows that one episode of a bleeding may take 15.54 days of a person of his life. So we can see that challenges of hemophilia is not very small. There are social impacts, physical impact, and financial impact, which by which the patients suffering from hemophilia are overcoming or taking in their day-to-day life. So for this, I am going to discuss about what are the diagnostic challenges which are faced by these people. Next slide, please. So the diagnostic challenges are 30% of the hemophilia carriers manifest low factor 8 or 9 levels. Since government has started to screen the female carriers of the families where the hemophilic patients are identified, so they had started to screen in the entire family. And when they find that there are a carrier, so here we can miss the some carriers which have a very low level of factor 8 and 9, because these patients may have lionization of the defective X chromosome. ABO type is also responsible for that presence of 1 millimeter factor or a low amount of 1 millimeter factor and severity of factor 8 or 9 mutations. Among the hemophilia A or B carrier, they are of two types. One are asymptomatic and the another one is the symptomatic, based upon the presence or absence of bleeding. Next. These I discussed among these are challenges among the hemophilia patients, particularly male, but there are challenges also associated with diagnosis of this disease among the females. As we know that some of all the females of male hemophilic person are carriers. So these patients are usually unnoticed, as it doesn't mean that they are clinically asymptomatic, but they are not notice their presentation or their clinical symptoms, because they are noticing that this is a normal part of their physiological changes. So this heavy menstrual bleeding is the most common symptom among female who have inherited bleeding disorders, which account 15 to 30% of cases. And the diagnostic challenges are lack of recognition between the difference between the normal and abnormal menstrual bleeding, or if they had noticed that and come to the physicians, there is the limitation or limitation of the availability of laboratory testing, because in such patients factor 8 activity, von Willebrand factor, factor 9 activity, and genetic mutations, these are the tests which are required for confirmation, and these facilities are not available at most of the centers. Apart from this, the how we could classify or nomenclature of the disease among these females, because nobody think at first line about the hemophilia among the female patients. And one of the most important von Willebrand factor type 2n or type 3 have presentations which are similar with the hemophilia. So these are the conditions where we have to be very careful that no patients, female patients who are complaining for heavy menstrual bleeding and have family history of their maternal uncles or paternal side, then we must have to be screened for hemophilia also. One study says that for every male with hemophilia, there are at least 3 to 5 hemophilia carriers, means females. So these are not a very small number, but since they are not diagnosed, they are just following the iceberg phenomena. 30% of the hemophilia carriers manifest low factor 8 or 9 levels. Next slide, please. So coming to the topic, diagnosis of hemophilia. So what are the laboratory tools we have available for diagnosing the case? So these are basically broadly classified into 3 different types. One is screening, another is confirmatory, and third one is the monitoring. For screening, we should use the first is CBC, second is platelet, that is for counting the platelets, second is PTINR, FPTT, and mixing studies. In confirmatory study, we have to do factor assay and genetic analysis. For monitoring, APTT, Bethesda assay, mixing study, and factor assay. These are the tests which are available for doing the confirmation of diagnosing and monitoring the patients with hemophilia. Next slide, please. So, how will you proceed with the screening of hemophilia? First, we have to do the clinical examination and taking a brief, detailed clinical history from the patient for presence of bleeding among his paternal or maternal side. If there is any clue or no negative history for bleeding, rather then also we could go for these 4 tests. One is the CBC to see the platelet count. Second is PT, APTT, and fibrinogen level. If PT, APTT both are normal, then platelet counts are also normal, PT, APTT are normal, then we have to test for von Willebrand factor by von Willebrand factor antigen, ristocetin cofactor. And if there another test is for factor 13 assay and platelet function assay. These are the tests which we have to do if the PT and APTT tests are normal among the patients who are having bleeding symptoms or bleeding tendencies. If PT and APTT both are prolonged with normal platelet count, then we have to do the mixing study. If mixing study is corrected, then it is because of the deficiency of factor, and now we proceed with the factor assay to diagnose the exact type of factor deficiency. If the correction is not happened immediately, then it may be the because of the presence of inhibitors. So we have to proceed further with the inhibitor screening test, which include 3 tests: inhibitor screening, second is Bethesda, third is the Nisbeten modification of Bethesda, Oxford test, new Oxford test. These are the tests available These are the tests available for the inhibitor assay. The inhibitors are again of two types: time independent or immediate acting. If there is a inhibitor screening will show immediate correction, then it will be because of the presence of lupus anticoagulant or factor 9 inhibitors. And if it happens after the incubation of 1 hour or 2 hour, then it is because of the factor 8 inhibitor. So these are the tests which are required for complete analysis of the hemophilia. So for screening, we have to start with the basic tests and then mixing study, followed by this factor assay or inhibitor assay. Next slide, please. So as I said, screening assay CBC will show platelet counts normal, and coagulation screening will show PT and APTT levels. Here, as I said, coagulation cascade are of two types: intrinsic pathway and extrinsic pathway. Intrinsic pathway will be diagnosed or will be indicated by this APTT test, whereas extrinsic pathway were evaluated by the PT. So, and this is the interpretation table which show the values of these three tests and their interpretation. If the only isolated platelet count is low, then it is a case of thrombocytopenia, and we will move forward on the diagnosis of thrombocytopenia. But if it is isolated PTINR prolongation, then the causes are very many, but most common were factor deficiency because of the underlying liver disease and another problems. But if there is or maybe of hemophilia, so we have to further take consideration for factor 8, 9 or von Willebrand disease as a diagnostic assays. Next slide, please. This is the entire list of this interpretation, as I mentioned, because we are here discussing about the hemophilia only, because this is an entire disease entities interpreted on the basis of these first line investigations. Next slide, please. So what else? What next? After screening, when we find that APTT is prolonged, so we think about that there may be a deficiency or maybe presence of inhibitors. Both are the possibility. So what we will do, we will do the correction study, and if this study will correct it, then we will move with the factor 8 or 9 assay. If it is not corrected, then we will move with the factor inhibitor assays. The factor 8 assay is of three types we are using. One is one stage test, second is two stage, and chromogenic assay. In some cases, mild hemophiliac mutations destabilizing the interaction between A1 and A2 domains result in one stage stay. Assay results higher than the obtained by two stage assay. So, what is the difference between these three assay methods of factor 8? One stage assay will start to measure the factor activity in multiple dilutions, whereas in two stage and chromogenic assay, we will identify the pre-activation of this factor 8 is required in one stage, which is get overcome in the two stage and chromogenic assay. Next slide, please. In one stage, these are coagulation factor activity is measured by activity present in 1 ml of fresh plasma from normal donors. So, and this is made considered as a 100% activity or 1 international per ml as a normal coagulation factor activity. In the normal range for factor 8 and 9 is from 45 to 158 international per real and 50 to 150 international per real. APTT test is sensitive for deficiency to diagnose deficiency of factor 8, 9, or 11 up to 35 to 40 international unit per DL. Next slide, please. So this diagrammatic representation is for giving the how we will interpret the APTT result if we do the mixing study. In mixing study, what we will do the we mix the 1:1 ratio of normal plasma and the factor deficient plasma or test plasma, and again perform the APTT and measure the value. So here APTTP is the normal this patient value, APTT normal plus plasma, and APTT measured. So if the APTT measured value is less than 50 or of the average of these two, or less than of the average of these two, APTT patient and APTT normal plasma, then it will be because of the factor deficiency. But if it is more than that, then there is presence of inhibitors. So and the next downside will show the how will we derive these values. And there is one index also which are used to predict the presence of deficiency or inhibitor. The cutoff limit is 10 and 15. If the Rosner index is less than 10, it will indicate that there is a factor deficiency, and if it is more than 15, inhibitor. But the values which fall between the 10 to 15 are inconclusive. So these tests will be again repeated among the when the RI is between 10 to 15. Next slide, please. So this is the graphical representation of the tests performed by one-stage factor assay. Here, the dotted line right side of the central one is shows the test one, test two, and the downside is shows the test two, and the continuous line is standard. The first one A graph is the single linear graph, and the second one is the double log graph. It will show there if we see the horizontal line between the standard and the test graph, linear graph, sorry, double log graph, the horizontal distance will show the potency or concentration of the factor deficient. So we can see that that the test line which present left to the standard line will show higher level of factor in comparison to that which is present on the right side. So on the graph paper, the right side graphs are showing lower factor levels, and left side will show the higher factor levels. Next slide, please. This again shows the factor 8, residual factor 8 activity, which we can see that at the 50% of the activity, the unit is 1. But when it is less than that, the unit will become higher. Next slide, please. So coming to, these are the factor assay we have done. Now we will move towards the diagnosis of inhibitors. So what are the inhibitors? Inhibitors are basically immune mediated factors which are developed against factor 8 or factor 9. So these are polyclonal IgG4 subtype, and in factor 8 deficiency, they are targeted against A2 and C2 domain of the factor 8 proteins. These antibodies are of basically two types. One have non-inhibitory antibodies, and another one is inhibitory antibodies. The inhibitory antibodies are following two types of kinetics. One is called type 1 kinetic, which antibodies have higher affinity, and that they completely neutralize the factor 8 activity whichever present inside the plasma. So the factor activity will all near to the 0% among the presence of higher affinity antibodies, whereas the lower affinity antibodies, which follows the type 2 kinetic, which is a very complex kinetic, and these antibodies have forming an antigen antibody equilibrium state, meaning that in excess of the antibodies, the factors still have some residual activity present. So these patients have some minimum amount of factor 8 still present, which are functional. So the methods of diagnosing these inhibitors are inhibitor screening, Bethesda assay, Nijmegen assay, Oxford assay, and New Oxford assay. So inhibitor screening is usually first we start with the inhibitor screening, where we perform the test with two different dilutions. One is with substrate and the patient plasma, and another is the standard and pool plasma mix. And with four to five dilutions we are using. Like if we think that inhibitors are very in less amount, then 1:5, 1:10, 1:20 dilutions are used. But if we think about that or assume that inhibitors are in high quantity, then we will use 1:10, 20, 40 dilutions. So first we will do the inhibitor screening, and after that we can use the Bethesda assay. Nowadays, Bethesda assay is the most commonly performed test for inhibitor screening, But there are drawbacks that these Bethesda stains are not standardized for pH and protein concentration of the plasma. So if the patients have a higher pH or low protein concentration, there is falsely high or falsely prolonged APTT values are we can see in the Bethesda assay. So it may give the falsely high level of Bethesda unit. So that's why the Nismusen modification was came in the Bethesda assay. That was there is we had done overcome this defect by using buffer zero point 0.1 mole in imidazole with buffered albumin as a you can say diluent. So this modification will overcome the challenges of change in pH and hypoproteinemia. Apart from that, Oxford assay will use the factor 8 concentrate, and new Oxford assay, the this clotting time will be measured after 4 hours. That is means usually we do incubation of 2 hours, but in case of new Oxford assay, the incubation time will be 4 hours. So why we will do this? Next slide, please. So this is a study from Kettler C et al. 2022, which showed they had experience. They had performed a in vitro test where they used 4 types of antibodies against factor 8 and tried to find the kinetics and its response of these antibodies against the factor 8. The A and B, that is 4A4 and the B0, will show the are the type 1 antibodies, and 254 and ESH8 are type 2 antibodies. Here we can see that with the time, the concentration will falling down. So this will show the time dependent kinetics of the factor 8 inhibitors, whereas these two antibodies show the residual effect of the factor 8, means type 2 kinetics, which I said earlier that there is apart from the high amount of presence of antibodies, they are failed to completely neutralize the factor 8 activities. So there is approximately 25% presence of factor activity are there. So next slide, please. This diagram is showing the Nismusen Bethesda assay for inhibitors, where there are two preparations. One is diluted patient plasma mixed with pool normal plasma in 1:1 concentration and incubated at 37 degrees centigrade for 2 hours, and for measurement of minimal residual factor 8 activity. The other one shows mixing of 1:1 buffer and pool normal plasma as a control, and it also incubated for 2 hours, and followed by measuring of the residual factor 8 activity, and this will be derived with a Bethesda graph, which is shown in the right hand side. Here we can see that the 100% the activity of the factor will be placed on the y-axis, and in a log scale, and x-axis will show the Bethesda units. So we can say that at the 60% of the activity, the Bethesda unit is less. So as the activity is low, the Bethesda unit is higher. So higher the Bethesda unit will show that presence of the in a higher level of inhibitors and lesser number of the activity of a factor. Next slide, please. So these are the tests which are right now almost the tertiary care hospitals or laboratories are performing in their labs under the coagulation profile screening and coagulation profile diagnosing. So but up to the Bethesda assay, the labs are doing these tests, but the genetic analysis is still a challenging process, and it is not available at all the centers. So but this is required. Why? Because uh, as we know, hemophilia is an X-linked recessive disorder where factor 8 is situated on the 28 of the Q arm of X chromosome, having 26 exons. Factor 9 is present on the Q arm of X chromosome at the place of 27.1, having 8 exons. So it is quite very smaller gene in comparison to the factor 8 gene. That is why we are seeing that factor 8 defect is much more common than the factor 9. There are, according to the hamsters data, there are more than 3,000 mutations which are present in the factor 8 gene, and more than 1,000 mutations are nowadays till date are noticed in factor 9 gene. So what are the types of mutations present in the genes of factor 8 or factor 9? These are of any kind, means there are large rearrangements, inversions, deletions, and insertions. Apart from that, splice mutations, point mutations, missense, nonsense. These all kind of mutations are possible among the factor 8 or factor 9 genes. Among the factor 8 and 9, factor 8 gene, the large rearrangements were found in the intron 22. So intron 22 inversion is the most common genetic mutation in the factor 8 gene, which is account for 40 to 50% of the genetic mutations among the inherited disorder, followed by intron 1 inversion, which is found in approximately 2% of cases. The intragenic deletions and insertions are also second most common type of mutational defects among these chromosome. And after that, single nucleotide variants, so missense, nonsense, and point mutations and splice site. In point mutations, the ALU its repetition is very much common. So approximately 50 ALU repetitions are there in factor 8 gene. So factor 8 gene mutations results what this factor 8 gene cause in hemophilia. It will increase the clinical severity of the case, increase the risk of inhibitor development, and decrease the response to immune tolerance therapy and choice of it's also important to decide the choice of appropriate treatment. Next slide, please. So, the genetic mutations are more broadly classified into two different types: high risk mutations and low risk mutations. In the high risk mutations, inversions and deletions are most common, and in low risk mutations, the point mutations, splice mutations, and the missense variants are important. In hemophilia A, 265 different large deletions were identified, where in severe hemophilia, missense mutations it constitutes 16% of cases. In mild and moderate cases, 75% of the cases are missense mutations, and the large deletions were seen in 3% of the severe hemophilia cases. In hemophilia B, the small and complete deletions of factor 9 were associated in 70% of cases of hemophilia B. Missense mutations are the commonest one, and the CPET study will show that null variant showed highest risk of inhibitor formation among hemophilic patients. Next slide, please. Apart from these Apart from these genetic mutations, there are also epigenetic mutations and post-translational modifications are present, which are influenced by environmental conditions or patient's his physiological conditions. So we can say that hemophilia is 4 times more common than the hemophilia B, and 30 to 33,000 males with hemophilia were diagnosed and having hemophilia in the US. More than half of the people were diagnosed with severe hemophilia A. Type 2 1 milligram disease and factor 8 and factor 5 deficiency are the important other abnormalities which are causing decreased factor 8 activity level. That's why this may impart misdiagnosis of the hemophilia. Next slide, please. So this diagrammatic representation shows the factor 8 gene structure and the is post-translational protein formation. So factor 8 gene will show the exons, and the color coding will show the respective precursors formed coded by these genes. We can say we here the A1, A2, and B. These three precursors will form the heavy chain, and the A3 and C1, C2 will form the light chain. In between them, the B and this C1, C2 region will be important for binding with the von Willebrand factor. So the one this factor 9, factor 8, and phospholipid membrane. These three forms of teenage complex. One Willebrand factor will bind over this region of the factor 8 protein, and in case of the one Willebrand factor deficiency, because of the deficiency of that factor, these heavy and light chains are not in continuity or and are not able to be functional or activated during the coagulation cascade. That's why there is functional deficiency of factor 8, and this factor 8 will get catalyzed from the blood. So there is factor 8 deficiency, not because of the defect in the factor 8 itself, but because of the deficiency of Waldenburg factor. Apart from that, there are some post translational modification among these protein or amino acid sequences that will lead to the acquired hemophilia. And the post your epigenetic mutations which are responsible for hemophilia are your methylation and ubiquitination. So these are the forms. This will lead to the miRNA, long non-coding RNA, and your circular RNA defects. And among them, the MIR 37, 4B, 5P, and MIR 30C, 5P are responsible for low factor 8 count. So, as I already told, that inherited hemophilia is because of the factor 8 gene defect mutation, which are of any kind. But the post-translational modifications at the level of histone, at the level of miRNA or long non-coding RNAs, or your splicing of the this protein sequences, or ALU repeat translations. These are called the acquired hemophilia. Next slide, please. Here is this diagrammatic representation of the inversion and crossing over of intron 22 among the factor 8 gene, which will show that mutated gene have the just reverse of the normal gene alignment of these genes. Next slide, please. This pictorial diagram shows the factor 8 gene, which has 8 exons. Here, the coding region will code for signal peptide, propeptide, GLA, EGF1, EGF2 linker, and serine protease. So again, the heavy chain and light chain are formed in the mature factor 9 protein by the sequential genetic coding and replication and translation. Here, there is the heavy and light chain will be linked with the disulfide linkage. Next slide, please. So, in factor 8 gene mutation, the epigenetic modifications are very important. So, miRNA may affect the severity of hemolytic anemia, but for some patients, miRNA-based interference might cause hemophilia A in the absence of factor 8 gene. And this, as I told, that epigenetic repression of factor 8 gene cause the non-coding RNA post-translational inhibition and direct repression of factor 8 protein. The RNAs can interact with factor 8 mRNA and suppress its translation, non-coding RNA and miRNA. Next slide, please. Factor 9 gene mutations, so 20 genetic mutations in the promoter region. Deletions are the most common one, and those in the exon region generate either frame shift or inframe mutations, and those in the introns usually cause aberrant splicing. Point mutations result in hemophilia B laden. This is important because these are the undiagnosed or underdiagnosed cases where we can't diagnose hemophilia because of the presence of hemophilia B laden. Point mutation in the coding sequence can be missense, nonsense, or slight mutations, silent mutations. The nonsense mutations produce a truncated factor 9, which are non-functional. So this may lead to the hemophilia B. The silent mutations cause aberrant splicing. That's why that affect the factor 9 translation. In missense mutations, the factor 9 translation, protein folding, protein stability, post-translation modifications, these may form they inhibit the formation of this functional tenase complex. Next slide, please. So now we move on the diagnostic challenges. As we here see that the screening and confirmation part of the diagnostic part is over. So what are the diagnostic challenges among patients of hemophilia? The most important was the pre-analytical errors that are related with the sample collection and processing. where there are different domains which decide or which may affect because affect the test reports. Apart from that, inhibitor screening and factor SA among prophylactic patients. These are the major challenges which our laboratory were facing among the cases of hemophilia. Next slide, please. The pre-analytical errors will start from the patient sample collection, where if the stress. Next slide, please. The first and most important is the method of patient sample collection. The left one is shows the normal plasma, which is transparent. We can easily appreciate the label letters through the plasma. But here we can't see the label through the plasma. Here we can see that there is a mark of the adequate amount of volume is here, but there is more than 80% deficiency of the blood which is provided for the tests in the lab. Another most important thing is the presence of hemolysis. You can see here 3 different degree of hemolysis which are present among the samples which collected for the PT or APTT test, and the presence of clot also. This may affect the APTT test, but the factor 7 test is not much more affected in hemolyzed samples. Factor 8 assay is very sensitive and it may get affected if the samples are hemolyzed or having already having the clots. Next slide, please. So what are the pre-analytical errors which the laboratory are facing? First is from the sample collection method. That is, if the patient is under stress or having heavy exercise, and after immediately we had collected the sample, then there is definitely a relatively high level of factor 8 or factor 9 we can find. Then the selection of the vacuum-tenors. The laboratory will advise that you should use a very good plastic material vacuum tenor with blue top and having the volume capacity of 1.8, 2.7, 3.6, 4.5 ml of whole blood, or with either non-vacuum or vacuum type, and with the anticoagulant present in the ratio of 1:9, that is trisodium citrate, at the concentration of 32 gram per liter sodium citrate. Next slide, please. Why this is important is here. This is the coagulation pathway where the calcium is playing its role in activating the pathway. This calcium is get chelated by this trisodium citrate and form the insoluble complex. This will inhibit the coagulation. So this happens inside the vacuum tenor. All the vacuum tenors which are supplied in the laboratory or in the hospitals, they have the fixed amount of citrate concentration. So once the sample will collected above the 50% of that level, or below the 50% of that level, the level of this citrate will be higher in comparison, or higher or lower in comparison to the blood volume present in that vacuum tenor. This will cause the either complete or either low this chelation of this calcium ion. This affect this entire process which we are doing in vitro by adding calcium chloride in our tests to perform PT and APTT. So if this value is get deranged, then we have to recalculate or make a calculation or correction for the level of calcium ion in the present in the test sample. So we should request here that do not keep aware about that do not send samples which are less than 50% of the level of the cutoff level in the your mentioned or available vacuum tenors, because it will require recalibration of the entire test and dilution, making dilution for the this presence of the level of blood available in the back tender. Next slide, please. Second thing is the level of hematocrit and running these samples. The hematocrit value, once it is very high or hemoconcentrated samples, then the citrate level will be balanced according or readjusted according to the level of hematocrit. Usually, the hematocrit will fall between 30% to 55%. So, the 61 to 39, 0.61 to 0.39 ml of citrate will be sufficient. So if the and this will be done in the laboratory when we will receive that's why CBC is important before performing the test of PT or APTT, to see the level of hematocrit also, and correlating with the citrate. If it is more than two standard deviation from the citrate level and hematocrit value, we have to readjust the ratio. Next slide, please. The in vitro changes in samples occurs when there is delayed transportation of the sample from the patient to the laboratory, because after the collection of sample, the platelets get activated and there may be decrease in the number of platelets and initiation of clotting mechanism dependent on the surface contact. So this will be advised that the transportation is as much as earlier possible by the clinicians. The venous occlusion will cause hemoconcentration, increased fibrinolytic activity, platelet release, and activation of some clotting factors that will hamper or that will affect the test results. Next slide, please. Again, the duration between the sample collection and processing is very important. If the sample is collected at room temperature, it should be processed within 2 hours of the after the sample collection. So means it will include the entire time of sample transportation, its labeling, its reconfirmation, its processing, and its your loading into the analyzer. At 4 degrees centigrade, if the sample is kept at 4 degrees centigrade, up to 4 hours, samples can be processed. Minus 20 degree up to 2 weeks, and minus 70 degree up to 6 weeks, if 6 months, if we have to preserve the sample. Centrifugation of the sample must be done within 5 hours of the collection, and if there is excessive shaking during the transportation of the sample from the patient side to the laboratory, then this will cause the hemolysis of the sample, partial coagulation, cell disintegration, and abnormality. And apart from that, if the temperature of the surrounding is very abnormally high, like in the this seasons, then this may also affect the level of coagulation profile, like PT and APTT values may get prolonged by 1 to 2 seconds. Next slide, please. Uh, as far as factor SA is concerned, after the factor replacement therapy for either prophylactic or on-demand therapy, the factor SA will be done after 15 minutes of the replacement therapy for factor 8 and after 30 minutes for factor 9. For desmopressin, at 30 minutes after IV infusion or 60 minutes after intranasal, we should collect the sample for assessing the factor levels. Underfilling or overfilling of the valve should be avoided. High or low hematocrit also taken care of. Contamination of the this your reagent from kaolin or platelet substitute with thromboplastin should also be avoided by the laboratory personnel. That incorrect concentration or not freshly prepared calcium chloride is also uh, hampering the result. Dilutional errors, difference in the composition of reagents, failure to take the time trend into account, or difference in experience and technique between operators will also affect the level of values of the PT and APTT or factor levels. Next slide, please. So what WFH recommends? WFH recommends for the laboratory practices in case of hemophilia that the internal QC and the ECAS should be followed as per the protocols. The internal QC will be done at least for 2 levels per day e- for the all test batches. So the day we will start, before we start the test for this coagulation profiles or hemostatic screening test, IQC will be done at least for 2 levels per day or at the before starting this test. So clinical laboratory routinely participate in external quality assessment also for each assay, which are used for diagnosis and treatment of hemophilia, because there are very discrepancies between the lab to lab the values and variations, the methods, the reagents, and the your laboratory personnel trained in the performing these tests are varying, so there is no uniformity as far as coagulation profile tests are concerned. So WFH strongly recommends that coagulation laboratories implement quality assurance programs for all laboratory systems to ensure quality adherence and reliability of laboratory reports. Next slide, please. So moving on the futures of diagnostics for the patients with hemophilia. The future in diagnostics for the patients of hemophilia will include the DNA gene sequencing, not only for diagnosis but for screening also. And this will help to diagnose or to identify the generation 2 patients, those who are asymptomatic and who are carrier. Apart from that, the patients neonatal screening by cord blood genetic analysis by doing the prenatal diagnosis and carrier detection techniques should also be available in the at least tertiary care centers. Then genetic counseling is also important, and referral system for the entire test panel should be developed in the country. Apart from that, the introduction of omics like proteomics, spliceosomes, and for epigenetic mutations, epigenetic modifications, and post-translational modifications, we should also have the facility for identifying these defects so that not only inherited but acquired hemophilia will also be diagnosed. Apart from that, the multiplex ligation dependent probe amplification is a standard test for identifying the large deletions and detection of female deletion carriers. So this MLPA should be the part of genetic testing among the centers. Next slide, please. So the take-home message is, as we saw, the diagnostic challenges in hemophilia are very high because of the variations in the laboratory part also, and variations from the patient part also, difficulties from patient's part, challenges having they facing. The encouragement of persons with non-severe coagulopathy to respect the follow-up of as the clinician advice or according to the WFH guidelines, whichever the institutions are following. This is very important. Apart from that, to assess the earlier changes in diagnosis and therapy is utmost importance to inhibit or to prevent the development of complication and decrease in the quality of life, because with the development, with the availability of such diagnostic tests and this prophylactic replacement therapies or some non-factor treatments which are coming on, the expected life of an hemophilic person is just equivalent to the average normal lifespan. So these people are quite able to perform a very good physical life with a good quality. So these patients are very much required to have the diagnosis earlier with the development of very sequential screening programs which have for with all the logistics and availability of nearby at the nearby centers. Apart from that, the organizations and the societies like World Hemophilia societies should promote the early diagnosis and management, should support the cost for diagnosis as well as treatment for people with hemophilia, and networking the private laboratory facilities so that the patient who have diagnosed and who want to monitor their inhibitor levels, they have the at least reach of these tests in their nearby area. Setting up coagulation laboratories in close proximity to hemophilia at the nearby to the daycare centers for increasing the awareness and improving the quality of life and reducing the requirement of this high level of factors among the patients. Apart from that, development, training, and quality control of for factor and inhibitor screening assess as frequent intervals should also be required, so that the each and every laboratories will become well equipped with all these basic tests. And taking care to minimize the pre-analytical errors is the utmost important, because 60 to 70% of the laboratory tests are just because giving the wrong reports because of these pre-analytical errors. Some were from the patient collection site and some are from the laboratory side. So these are my take-home messages, and I am just keeping here my voice, and thank you. And I'm welcome to if any questions are there.
Thank you, Dr. Pushpanjali, for a wonderful talk regarding the hemophilia management, uh, from the diagnostics to the clinical aspects. That was fantastic. Now, I request all our discussants to please put the raise hand sign so that we can start our question answer session with Dr. Pushpanjali.
Hello.
Yes, sir. Please go ahead, sir. Dr. Sashidharan, sir. Please, sir.
Yeah. Thank you, Dr. Pushpanjali, for the excellent talk. I just wanted to share some thoughts because we had difficulty in diagnosing and managing, and we never had a free factor rate for prophylaxis till I retired from the government medical college. Now it is available freely with the government support. It is just started only because though it was started in 1970, the prophylaxis treatment started in 1970. It is just started in our scenario. In Kerala, with government support, we are now having free factor rate availability, and prophylaxis has just started. Now it is doing great benefits to the severe hemophilia. And diagnosis is always a challenge because we now had factor rate as properly available. Even now, the errors due to sample collection and the techniques are still there. We have to depend more on clinical plus laboratory. That's how we have to diagnose also. And the introduction to primary prophylaxis, I knew only in 2004 when I participated in a World Hemophilia Conference. That time only I came across the possibility of giving primary prophylaxis. Till then, we were not even aware of it. Anyway, that is a scenario that we were working with. We were giving only FFP, not even factor rate, even when it is on demand. But factor rate also is available only now. Till then, we were managing most of them with the FFP only. Another point is that because of the limitations and financial constraints, we were managing our patients with other non-pharmacological plans also. Like, for example, those who bleed from other sites are due to or poor orodental hygiene may be the cause for bleeding from gums. Similarly, hemorrhoidal bleeding may be due to poor dietary habits. When we modified all those, the bleeding episodes were much less. Even weight reduction can reduce the hemarthrosis. So such non-pharmacological management also has to be relied upon in Indian context. And some of the new mutations, we had two patients at least with a fresh mutation with no family history. And these patients were, I went explored, we found that they all had wrong diet and lifestyle habits. So probably these epigenetic factors may have some influence on new mutations. So that is another thing that it was interesting to me. I just wanted to share these thoughts with you. Thank you, Dr. Panili, once again. And thank you, Mumbai Hematology Group, for involving us. Thank you.
Thank you, sir, for your words. And I just want to add one thing that whenever the patients, you had started factor 8 replacement over there. So after at the first time, after first replacement, you should go for the inhibitor testing because there are two kinds of inhibitor: high affinity and low affinity. And if the low high affinity inhibitors will get detected with the one first episode of this factor 8 replacement. And if the inhibitors are not there, then you may repeat the test after 20 episodes at minimum, or at per WFH guideline after at least 50 episodes. These episodes may include the your on-demand therapy or your prophylactic therapy. Whenever the replacement is of factor rate of 50 episodes, you must go for the inhibitor assay. If they are negative, then please keep your patients on every 6 monthly inhibitor profile assay. because if the inhibitors are there, there are some drugs which are used in place of factor 8. And as I said, that recently introduced emicizumab, which is not a non-factor monoclonal antibody, which is very user friendly, and there is a very little chance, but still there are chances of development of inhibitors. So in my recommendation, you should start inhibitor assay at least when there is you are going through either your plasma derived or recombinant factor 8 replacement, either a short half life or extended half life.
Thank you.
Thank you, sir. Dr. Bipin Kulkarni, your question.
Yeah, so first of all, thank you, Dr. Pushpanjali, for that wonderful talk. And you have touched upon all the aspects of diagnostics, management, and all the challenges that we faced, and both in diagnostics as well as treatment. So, just a couple of points I would like to make. Uh, Whenever there is a diagnosis of factor VIII deficiency, uh, this is a common observation that only factor VIII assay is done and the patient is labeled as hemophilia. So the laboratories who are diagnosing hemophilia or factor assays, whenever you find a factor VIII deficiency, please go ahead and they should also do the von Willebrand antigen before labeling the patient as hemophilia A, because that's a common problem that we face because the genetics is different of hemophilia and von Willebrand disease. So that is point number one. Second is when we are doing the assays, the one stage assay works fine provided we take into account some of the variables that can affect the one stage assay. The APDT reagent itself, the source of phospholipid, the concentration of phospholipid, the activator in the APDT reagent. Because as we now know that if if the treatment center is using extended half-life factors, then there are specific APDT reagents with specific activators which should be used. Otherwise, you will end up either grossly under reporting or over reporting the factor levels. So that is another thing that is to be considered. And the third point is nowadays when the patients receive emicizumab, none of the conventional assays, the factor assay or the inhibitor assay, will work once the patient has received even a single dose of emicizumab. So that has to be kept in mind that whenever we are taking a history, we have to take history of infusion of emicizumab. And if the patient has taken emicizumab, please don't do any of the conventional assays. The WFH in their guidelines have wonderfully explained, what assays the bovine reagents have to be used for doing the assays when the patient has received emicizumab. So these are just additional points I wanted to make. Your talk was fantastic and congratulations.
Thank you, sir. So thank you, sir, for adding these points. And this is, you are truly speaking that for emicizumab prophylaxis, you must go through the APTT test by bovine factor 8 for as a test material, because these bovine factor 8 is not affected by this presence of the emicizumab.
Yeah, so these are
So
chromogenic assays actually. So
yeah,
not the APDT based. So even
yeah.
even if it is a uh, uh, one stage assay, we have to use the emicizumab calibrators under specific conditions. So otherwise, these are chromogenic assays using bovine reagents.
And sir, people should not be get confused with the routine APTT which we are doing for just knowing the prolongation or inclusion of this coagulation factor pathway abnormality. These APTT reagents are quite different from the APTT reagents which are used for factor assays. For factor assays, the kit itself you have the APTT reagents which are used for that particular assay only. So, if a person who is wrongly use these routine APTT reagents for doing the factor 8 assay or 9 assay, there might be a different results, as you said. So, just this is an important point to be get
Yeah, absolutely.
by the technicians. Thank you, sir.
Thank you. There is a comment even by Dr. Rucha Patil. First of all, says congratulating you for that excellent lecture, and
Thank you.
all points are very beautifully covered. And just her input that with new non-factor treatments which are available now, all the tests about chromogenic bovine tests should be standardized now.
Hmm. So,
That's
so these are because these are the non-factor prophylactic agents are just recently introduced. So the people are not very. We also don't know at which frequency the assays will be done or assays done or not. So because these patients have very less frequency of rebleeding. There are least chances of rebleeding also. So these people are may not be get motivated to get follow up with these laboratory tests. And which tests we are going to perform at which extent, what are the calibrations and what are the standard for that. These are underway, sir. We are just looking for these factors response and their real challenges which are coming.
Thank you. Another same comment from another audience that all the points are very well covered, extensive talk, and excellent talk. And still, most of the centers they really face is diagnostic challenges which needs to be solved. But newer agents are of great interest, and time will tell us what the results will come up in the near future. Any comment on acquired von Willebrand disease diagnostic challenges and acquired hemophilia diagnostic challenges? That is the next question one of the audience has asked about acquired von Willebrand disease or acquired hemophilia. Any diagnostic challenges and how do you diagnose those patients with hemophilia?
Yeah, as far as genetic part of analysis for these factors are concerned, there are challenges because as you know, this is inherited disorder, so we are focusing our investigations of the genetic analysis or DNA analysis
We cannot hear you, Dr. Pushpanjali.
for
Your
these
voice
patients.
is
We
breaking.
have more genetic mutation or most modules which are protein sequence of these genes. Hello.
Your voice is breaking. We can't hear you. Uh, now it's clear. Just speak again, please.
Yeah, that genetic art is concerned, this will get connected to this all the diseases because more the tests we deliver, we know your genetic and protein post-translational modifications. So most of the laboratories are not doing or not thinking about that line. There is no very much standardized protocol that so and so markers should be utilized. There are some studies which are performing some markers and which are performing the other markers and try to find out some mutations, and it also find out that there have some mutations which they find in their studies. So these are the things which happening in case of acquired disorders. In case of inherited, there are the hamster and the human genome database already have the known mutations, but for epigenetic and post-translational modifications, because it is environmental induced and there are multiple factors underlying uh, in this, so identifying this just finding out a needle in a has kind of thing. So this is a very important genetic challenge in diagnosis of acquired or hemophilia or one Willebrand disease. But as far as factor say is concerned, this is not a very big challenge because we are just looking for activity of these cases. So and the confounders were get taken care of by this Oxford and New Oxford methods, these modifications. So activity is mild, moderate, and severe factor activity we can find out by our laboratory coagulation profile assays. Genetic assay will be a challenging task among these acquired conditions.
So,
That is from my side, but
thank you. So there are no questions from the audience. Any discussions want to ask any other question? Want to comment? Want to advise? Anything? Well, so there are no raise hand signs and no more questions from the audience. Well, Dr. Pushpanjali, that was a fantastic lecture. We had a great learning. very extensive talk. You covered almost everything in detail, starting from the clinical aspects to the laboratory aspects, one stage factor assay, modification, the Bethesda assays, as well as the inhibitor testing. From the clinical to the laboratory, everything was so perfect, and you delivered your lecture so beautifully. Thank you so much for accepting our invitation as the speaker, and your talk was fantastic, wonderful. Hats off to you. Thank you so much. And I
Thank you.
thank our discussants as well as audience to participate in this webinar. Meet you next Saturday, Sunday with another two beautiful webinars. Thank you. Thanks a lot.
Thanks.